Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
All right, welcome back to another episode of Pod Patrol with your host, Dr. Jeff Dikis. Today, I'm joined by Dr. Mark Mendeszoon. Thanks for joining me tonight.
Thanks for inviting me. I appreciate that.
Yeah, absolutely. So going back, you kind of started out the Philadelphia School of Podiatric Medicine, now Temple, did your residency in Boston, and now you practice with precision orthopedic specialties in the Cleveland area. So tell us about kind of how you came to work with the orthopedic group.
Sure. Well, my life is never a straight path. So from undergrad of going to University of Pennsylvania and getting in and not able to afford it, I had to scramble. My track coach, made some calls and back in the early 80s, there's no computers and things like that.
Yeah.
So he ran at Kent State University and said that, hey, you ever hear of Miami of Ohio? And Miami offered a full, academic and athletic package. I'm like, never heard of it. I'll go there. And it was I was a track and field athlete, a hurdler.
Yeah. And
it was interesting, New York City, Long Island kid moving to the middle of nowhere in Oxford, Ohio. It was a culture change.
I bet.
So I wouldn't say it was the easiest path, but got through. And my reason how I got into podiatry is my roommate, who is a dentist now. He said, "Hey, Zoom, you don't seem too happy with what you're studying." He goes, you got a lot of foot problems. My cousin's a podiatrist in Florida. Works maybe 3 days a week, has a good living. You should think about that. I was working as a chemist with my brother, who's a podiatrist now at Boston Medical Center, the director there. So when I went to Stony Brook University, my high school coach became the track coach there. And he gave me his first graduate assistantship. And I did that for 2 years. And I was still coaching at the college level and still running competitively, and decided I didn't want to be a chemist. So I decided to go to podiatry school, and I wanted to go to the California school. But with my mom being in New York, I wanted to be close by because she was having some health issues. She lived by herself. So I went to Pennsylvania, and at that time, there was like an affiliation with Penn. And at that junction, the coach that recruited me remembered me, and he let me train with the team, gave me a locker. And I was able to eat with the team and train with the team and compete with the team. Had the opportunity to go with Dr. Havishall and Dr. Girini and Rosenblum through the Harvard system. And my best friend in podiatry school got the spot. And it was the first year they opened up a second spot.
Nice.
I went to Boston. Then I was going to go to the University of Washington and do the track coach position and sports medicine fellowship over at Fifth Avenue with Richard Boucher. And that fell through a few weeks before. So I scrambled, came to Cleveland, worked with a podiatrist. He had some affiliations with Precision Orthopedics back in 95. We shared some offices, and it was just a bad situation. So after a year and a half of not doing really well and just, doing 3,000 nursing home beds, home calls, business like that, it wasn't what I did to train. But with my track background, athletic background, we had 8 high schools. So my current partner, who's a sports med guy, says, "Hey, could you cover some games for us?" So I did that. That was my social life. Yeah. And that's how I joined Precision in 1997. And back then it was, very unusual for podiatry to work with orthopedics. And it's been since 97, I've been full partner, and it's been a very, very good avenue. Now, I won't say it's easy. We have ups and downs as anywhere else. But for me, I've been very grateful. So then my first 2 years when I joined the guys, I became their fellow. And so I created this 2-year fellowship where I did every orthopedic procedure you can imagine: hip, back, knee, shoulder, scope, shoulder scope, total joints, fractures. And they just brought me along and taught me. Mm-hmm. And I remember when they hired me, they say, "You're a surgeon, right?" I go, "No, I'm a podiatrist." I go, "No, you're a surgeon. We're going to train you, going to keep you out of trouble." And from everything I learned from them, I read every night, and I studied for my boards. And within the 2 years, I got board certified in every board out there, and including barefoot, and just built my practice slowly, and seeing patients at night, seeing patients on the weekend.
Yeah. So what would you say to someone that's kind of stuck in one of those nursing home jobs? Because I don't think that's anyone's dream, but sometimes it just works out that way. So, what's your advice? What was your best advice to try to get out of that situation that someone else listening might be stuck in and end up with such a good job on the back end of it?
I think beauty is in the eye of the beholder, right? And I think the reality is that you have to pay bills, right?
Yeah.
And for me, when I was doing nursing homes, I'd get up at 4:30 in the morning, get them before they would leave, and start, migrating before breakfast time. But what you learned is like panning for gold. You try to build your practice. So then from chipping and debriding nails and calluses, you start finding wounds, and then you start, I had a big wound care aspect and going from there. But I just wasn't happy, and physically it took a toll. So I am ambidextrous, thank God, because you do 150 set of nails a day, that's a lot. And then I'm 6'3", I'm shrinking now, but bending over, squatting down, I started getting some lumbar issues.
Yeah.
And it wasn't something I wanted to do. Being in the car, it just wasn't me.
Yeah.
So I knew I was planning on trying to do something differently. And I met my wife through Cleveland, and I said, look, I can either go back to Boston, go to Florida with my colleague, or take the fellowship back in Seattle. And then this opportunity came up. And I remember today, it was December 19th, 1996. I had dinner with my partner, Mike Kellis. And he goes, Mark, what's going on? I said, Mike, I'm leaving. I'm not happy. It's not good. He goes, well, would you consider working with us? And I'll clean it up for you. I says, well, there's a bear poop in the woods, right? And he said, let me talk to my partners. And, I sat down with them, and they have been tremendous. They're like brothers, and we're like family. So I've been very fortunate. So I would say if you've been trained and you know what you want, you got to knock on doors. You got to work super hard. You got to still grind and make things happen.
Yeah, I always kind of push that aspect of things on some of the earlier episodes. I talk a lot about networking and reaching out to people, and you never know who you're going to meet at some point may benefit. And so in your practice, it sounds like you're obviously into sports, which is how a lot of people find the field of podiatry. So specifically running. So you end up seeing a lot of athletes and working with athletes, both now and historically. So tell us about kind of your involvement with athletes in the Olympics. And
well, I competed at a high level. I ran a Division I. I ran post-collegiately. And track has always been a good thing for me. It really, if it wasn't for my high school coach, it was like my surrogate dad. It really got me out of not a good situation, I would say. So I was blessed that a man would put such an investment in me, who wasn't a great athlete, but what it did teach me is a lot of dedication and discipline. And you just wanted to perfect your craft, and being a hurdler, you just go over and over and over again. So I always knew I wanted to be in sports medicine when I graduated from PCPM. I looked at I don't have a yearbook. Someone showed me, and they sent me a picture and said, oh, most likely to be an Olympic doc. And so when I moved out here, we had 8 high schools, and I've been the team doc since '95, covering every football game. And I've been fortunate that I've been able to be on the sidelines, be part of the team, be in the locker room. My kids graduated 4 years ago. My son played football. My daughter ran track. So to be part of that community was great. Mm-hmm. Friday night football, there's nothing like it.
Yeah.
So I started the indoor track program in 2001 at Chardon High School. And then that summer, a buddy of mine who ran at Michigan, we started the Maple Leaf Track Club. We started with little kids, 3-4 years old, to kids in college. And we just wanted to build, because football is so predominant in Northeast Ohio, and Ohio in general, that we wanted to build a running culture. Not everybody could play football. And so with that in mind, we started the Maple Leaf Track Club. I started, getting kids, then starting to send kids to colleges. And I probably sent several hundred kids to colleges, and, probably secured, I would anticipate, at least over $5 million in scholarship money for them.
Wow.
And then in 2008, Spire Institute in Geneva, Ohio, I heard about it, and I met the gentleman who I became very close friends, and it's Olympic Training Center, Olympic Training Facility, or site. You got to be careful with the technical terms. So I helped design the track, helped build the track program. Coincidentally, the 2 coaches from Penn and from Penn and the other guy went to Cornell. They both came out here, and I hired them to run the track and field part. And then I started working with high-level athletes, and in 2012, where I had about 8 or 9 Olympic athletes, and the one athlete who won the gold medal in the women's pole vault became friends with her. She sends referrals, so it just perpetuates. And just over the years of just getting your name out in the track and field, working with kids in all different colleges and things of that nature, and your weekend warriors. And then in 2006, my wife and I opened up Achilles Running Shop. Why not? And that was a learning curve, because you think, oh, I'm a podiatrist, I'm a track guy, it should be easy. Selling shoes is a whole lot different than medicine. So, just that whole vibe of coaching and helping patients. And then I was able to go to 2016 in Rio. And even though one athlete got really sick and got the Zika virus and favored to win, one of the athletes took third to 800. The one girl that moved here from Greece won the pole vault. Then in 2020, a girl from Cleveland won vault. And then the ladies and the group that I worked with who won 12 are coaching now. And their athlete out of the blue made the Olympic team this year, out of the blue. And so I'm going next week. There's a couple of athletes that are going, so I'm going to hit the tail end.
Let's talk about training athletes in our field. You know that they can be very, have high levels of expectations and maybe unrealistic expectations of when they want to return to sport. So what are your thoughts when you're kind of talking to athletes and trying to not give them too much bad news? When I see a football player or a basketball player, I struggle giving them bad news and saying, so I try to sugarcoat it. And then I realize, well, maybe I'm not giving them the full information. So how do you treat that when you're kind of talking to athletes and maybe it isn't such good news?
Honesty is the best policy. And having all the injuries I did in my career, I knew how poorly I was treated. So I always was empathetic to athletes, and I never sugarcoated. I never lied to them. I try to talk the jargon, the language, understand the biomechanics of their sport. But the reality is they come and see you and they're like, look, I will do everything in my power to help you, but this is your condition. And if we don't follow the rules, you may not get back. Here's my phone number. Here's my cell phone. You call me. Not only would I treat them from a recovery standpoint, but if it's like track and field athletes, I would call the coach and say, hey, can I get involved and create the rehabilitation program under your guidance, and let you know what I want to do and get them going. So understanding the modalities, understanding the colleagues that we have, from physical therapy to chiropractic treatment to massage therapists, building that network. And most importantly, diabetics are tough to treat, but athletes, they're a different breed, as you know, right? And then when you start dealing with people who are making a living from it, and track and field is not a sport where you're going to make millions of dollars. So if you don't perform, you may be done. Or if a kid's looking at a scholarship, or even at the collegiate level, right? You look at what they're doing to get these kids back on the field. So every level, has its challenges, but particularly when you work with younger kids, I think one of the biggest things that concern me is when parents push their kids too hard. Doing 3 sports in one season, right? Going from soccer to ballet to swimming. And you have to try to, I always tell people, it's the coaches, it's the parents, and it's the kids, but don't forget the children or the athletes to explain. And then if you work with some professional athletes, now you're dealing with the agents, right? And you're dealing with their coaches. So it becomes a little difficult. But I think understanding, explaining it, trying to do everything in your power, and with the stuff that's going on now from rehabilitation, with all the treatments that are out there, we can expedite and try to get people back somewhat safely, but you want to make sure they don't jeopardize their future. So it really truly is a jungle.
So let's dive deeper into that, because obviously most of the people listening are going to be students, residents, or practicing physicians. So they'll have a pretty good understanding of what we're talking about. So if you're talking about rehab protocol, obviously I understand it depends on the injury, but what are some of those things that you're recommending as part of the rehab protocol? Are you one of the early range of motion kind of rehab strengthening platforms, or what are your thoughts on that?
I think there's so many modalities and school of thoughts depending on injury. So ankle sprains, do you immobilize, don't you mobilize, right? And you should be able to have a good understanding of the degree even before an MRI when someone comes in, right? And what sport are they playing? and what do you have access to? So I definitely think that if at all possible, early range of motion, isometric strengthening, mind exercises to keep them engaged, core flexibility, trying to see if you trust them to get them out of a cast to do a non-weight bearing range of motion if a surgical procedure is performed. And then if you get to that acute phase, now the next phase is, okay, let's start rehabbing. And some of the modalities of physical therapy, whether it's laser, well, let me come back. Now, like even regenerative medicine, PRP, regenerative medicine, depending where you live in the country, some people may pay for that. Here, it's kind of sketchy. Some people don't have that type of income. So you have to understand that shockwave therapy. There's a product that I use that we're actually writing. It's a German product. It's called Tramiel. Tramiel I've been using on athletes, and it's a great natural anti-inflammatory injection that doesn't give you the negativity of steroids. That could be helpful. Grafting techniques, active release techniques, cold stim, dry needling. So these are all things that are coming through. Blood pressure restriction, when we put BFRs on, blood flow restriction to try to get people back and trying to get their strength. So trying to talk to people and really, like I teach the sports medicine class at Kent State. And I'm like, we're going to look at the big picture. Yes, we're podiatrists, but we have to understand how the body works in total.
Yeah. So what are your thoughts on PRP? I know the research is kind of mixed, and
it's mixed.
At some point, if people, in my mind, so at some point, if people think that it's helping, then it is helping. There is some placebo effect there. And if they think it's helping, then it is helping.
Yeah, you're right, Jeff. It is definitely something that, there's not great evidence with it, but if people hear it and if it's mind over matter, then that may be helpful. I think in soft tissue cases, it does well with, calf strains, maybe calming down some of the inflammation around the Achilles. But, as far as joints and things like that, I'm not going to say it's not helpful. But once again, I think in the community that I'm in, I'm kind of limited because people aren't kind of fixed budgets. Maybe in Miami or LA or New York, they can do that and they do that. But I would say that, if it works for someone and you explain the pros and cons and explain, it can help, it can't help in conjunction with other things, I think you give the people the best advice and information to determine what would be best for them.
Yeah. So how do you view yourself? I envision, I think I already know the answer, but, do you view yourself as kind of a cog in the wheel with physical therapy, with athletic training, with coaches, and you're kind of filling that piece of the puzzle to give information, but then it's ultimately up to the athlete to complete their rehab and complete the other components? Or how involved are you after you've kind of made a diagnosis and given a recommendation?
I am exquisitely involved. And I do speak to a lot of people, and I do have my system and my network of appropriate people. But I would say you're kind of like the conductor of an orchestra, right? You're moving parts, you're getting different groups to start moving, people getting going. And I have an active role in that. And if they say, Mark, maybe this isn't working, let's try this and that. And I'm like, okay, tell me why you want to do that.
Yeah.
Say, come over and take a look. This is what we're doing. So I have an active role. I got a phone that probably has 2,500, if not 3,000 names or phone numbers that will call and talk to people. But I try to take a very active role, especially when they start getting back to conditioning. And I'm a big person, core strength and flexibility are so tremendously important. So with the physical therapist, with the nutritionist, we have them, with the chiropractors, we were all on speed dial, and it would be great to make a consortium of people and just have a referral. But because we're not under a big umbrella, it's kind of tough when we're a little bit apart. But I do think that talking to the trainers, having your number, speed dial, I think if you do that, yeah, it's pros and cons. You don't want everybody to have your number, but I'm like, hey, people can find and get in touch with me regardless. So having a proactive approach, listening. But if a patient is coming from my office, or if I've done something surgically, I'm definitely going to take the lead until I can get them to that next phase.
Let's go back a little bit. You mentioned that you opened a running shoe store. And so what was your thought process behind that? If at some point, if you're recommending enough shoes, then you might as well kind of be involved on that end as well.
Yeah. I think even to today, you really don't realize the impact and the technology and science behind shoes. Now, I know it's not an end all be all, and I know it's not going to fix everyone, but it can make a world of difference. And in the world of insurance, where orthotic devices are very difficult, nowadays to get covered. And once again, I don't have that luxury of charging people cash all the time. They don't have that.
Right.
But you got to think of some alternatives. And for me, what was the catalyst way back when was that I was tired of sending people to the big box stores. And then, they just get a shoe. What's on sale? Or you got a young kid who knows nothing and they throw a shoe on and they come back. It's not fitted properly in length or width. It's not the right mechanical or biomechanical shoe for them. I tell them, look, there's no insurance going through this. I give people recommendations. So our stores carry everything. You get a biomechanical exam. Our staff is pretty well trained, and it's going to take you a good 30, 40 minutes to get into the proper shoe. It's a process of selection. So my philosophy was, why not have podiatrists who know mechanics and know feet, that they would be the best people to open up a store.
Yeah. I always tell my patients when they go to the shoe store, they'll probably pick the blue one, but the blue one probably wasn't the best shoe for them. So it's interesting how people pick shoes, and I do the same thing. I go and I say, oh, I like these. I like these. Maybe they are a good shoe for you and maybe they aren't. So, you know what? It's hard because, like you said, you do a biomechanical evaluation for these people, but not everyone lives in the Cleveland area. So what would you tell the average patient that isn't going to go get a specific biomechanical exam?
Right.
Do you have some tips that you tell your patients, hey, look for this, this, or this?
Absolutely. No, I think first and foremost, it's comfort. And if wherever people live, there are enough, running stores in the areas. And if not, then, get some guidance from your podiatrist, right? If you're seeing a podiatrist or a therapist, they have a general clue, like, hey, you need this type of shoe. You need to be measured up properly. So I would tell people when they don't have that access, do the wet test, right? You can go online and say, what kind of foot type? Go stand on your driveway or go stand in sand and see if you got an arch, no arch, or flat. And take a look at that. And then you can stratify what type of shoe that you may want. But online there's an infinitum amount of material that people can at least be guided to go in the right direction. And then even if they go to a big box store, there are some pretty good brands that they can look at as well. So I think that's kind of the simplest way.
So we aren't sponsored, but what are some of your favorite shoe brands? Because I get people asking me all the time, and I can rattle off a few names, but what are your kind of go-to reliable shoe brands?
Yeah, I think that's a great question. And I would say I plead the fifth because there is no great shoe brand. It's for the individual. However, if I ask you, what is the hottest shoe right now in the market? You would say Hoka.
Okay, yeah.
I want a Hoka. I want a New Balance.
Yeah.
Okay, that's just a brand. And if you're a nerd like I am with running shoes and the history of running shoes, about 10, 12, 15 years ago, the hot shoe was the minimalist shoe, the 5 fingers and the shoes with no arches, right?
Yeah.
And it said that, it can solve a lot of your problems. And I do still have a few pair of those, and it's great to work the intrinsic muscles and it protects your feet. But you have to understand, since 1972 is such a pivotal year for us in Western civilization, especially America, because we've changed the construct of shoes. Back when I was a kid in the 60s and 70s, it was the Converse, it was the PF Flyers, just flat. Those were your original minimalist zero drop shoes. But in 1972, Nike changed the whole world. Foam rubber, higher heel. Now you hear things about, heel drop. What's my heel drop? Well, how much is it? And it just changed. So if you think about the mechanics, when you have a zero drop shoe, you walk barefoot, you have full extension of that Achilles. Once you start putting yourself in a heel drop, which is usually about 12 millimeters, what can happen is that you can get contracture of that Achilles over time just from that type of shoe. 90% of us in at least America and Western civilization generally has some form of equinus, and you can talk to the experts about that. And we know how powerful equinus can be, but a lot of that has to come from that type of shoe that we've been wearing basically for most of our lives. So all of a sudden people are getting into these zero drop minimalist shoes, and they're like, it'll fix things because people in Eastern Africa don't wear shoes and they have no foot problems like bunions and hammer toes and blah, blah, blah. have skin condition. And then people started running, they started getting injuries. So about 7 years after that, there was a class action lawsuit. And that's why you don't really see the 5 fingers around, in those minimalist type of shoes. Still a great shoe for individual.
Yeah. Yeah. So how much do you think it's the shoe versus what's inside the shoe? Because, sometimes I think it's the shoe, but I wear Nikes, which are not known to be good shoes, but I put some inserts in there and they're really comfortable. So how much do you think the shoe plays a role versus the insert versus maybe a combination of the two?
Yeah. I would say the shoe is your foundation, right? So you need a good foundation based on what foot type you may have, what body type. Not everybody who has a shoe needs an orthotic. I would tell you probably 85 to 90% of people who are in that standard deviation or whatever we call normal or an ideal foot can go into a moderate support shoe without an insert or orthotic and do very well.
Right.
So I would say the shoe is priority number one to fit comfortably with length. Does it have a nice insole that you can remove and place with an insert? And then the orthotic device or the custom orthotic or the over-the-counter insoles would be second. Nike, like I said, they have a great marketing tool. And I think that they do make great shoes. Their track and field spikes are phenomenal, top of the world. And they have really good running shoes, but Nike is generally cut a little bit more narrow on the forefoot. So if somebody has a really wide forefoot and if the shoe is tapered narrowly, that can be somewhat of an issue. But yeah, I think all brand shoes have their pluses and minuses. You just have to be able to understand that not one brand is the end all be all.
Sure. So what are your thoughts on the barefoot? We talked about the Vibram 5 fingers. So you kind of mentioned it, the benefits to the intrinsic muscles of the foot versus kind of immobilizing them with a heavy constructed shoe. But what are your thoughts on barefoot running versus minimalist versus, because some of those, you're the expert, I'm not, but some of those running shoes are quite minimalist. There's not much there, especially the track shoes.
100%. Where was I? I was at the Guardian Mile this race in Cleveland, and there were a couple of people running barefoot. And I'm thinking, oh, Lord, that's got to be brutal, right? Running on cement, running in the city.
Yeah.
I don't know how people do it. Right. I hate being barefoot. So to me, it would be a minimalist shoe. If you want that barefoot sensation, then there are minimalist shoes that are still out there that you can get that allows your foot to function. But once again, there's a transitional period that if you're wearing standardization shoes or standard shoes, lace-up shoes, and you've been running 50 miles, you're going to have to break in that minimalist shoe slowly. So your mechanics are going to alter and change. So you have to break those in slowly and not go crazy. But once you adapt to it, then that's fine. But I don't agree that. I don't understand how people run barefoot.
Maybe it keeps us in business because they're going to step on something and they're going to need to come see us. So
yeah,
maybe 100%. We should promote that. Yeah, go run barefoot.
Yeah,
Go for it.
Yeah. So people say, so I told people, and jokingly, I said, well, I could see him in the office, or I could see him in the store. Either way, I may see him, right?
Yeah.
But I think that shoes have such an impact on people. I'm just, it's a big part of my practice. To understand and educate the biomechanics, which I love, and then, about shoe gear.
Sure. So you have a couple connections to me here in the state of Iowa. So both your son and then you do some kind of adjunct work with the Iowa State University. So let's talk about both those things. So let's talk about your son for a minute. He plays for Iowa State University football team.
Yeah. So my wife and I've heard of Iowa State, never knew about it. And this was during COVID, and I have twins, and my daughter's there as well, and she was a runner. And so after the whole process, we were shocked to hear from Coach Campbell. And I'll never forget, it was the first day back in 2020 that the world shut down. And Miles said, hey, Iowa State called. I go, yeah, right, whatever, because no big schools were really looking at him.
Yeah.
And he really wanted to play football. He was a really good track athlete. My daughter was a solid mid-distance runner, so they both wanted to go to college. And so we went to Miami of Ohio, and we went there for a second, visit camp day, and they blew him off. And it was the day Kobe Bryant died. And we came out of the car, and he was devastated. And he goes, Dad, they didn't want me. And I'm like, all right, dude, you really want to do football? Goes, yeah. I said, all right, let's go to plan B. Let's look at the Ivy Leagues. Let's look at like the Patriot Leagues at Georgetown's, Fordham's, those smaller type D1 schools.
Mm-hmm.
And my daughter wanted to run, and I have some connections in the track world. So that Friday after the first call, Miles says that Iowa State made an offer. And I go, what? I look at my wife and I call the coach. So the connection is Coach Hewitt, our Chardon High School coach, and the Miles team won state that year. He was a fifth-year senior at Bowling Green when Coach Campbell was a grad student.
Huh.
And that's the connection. And Matt Campbell and most of his staff is from Ohio. Mm-hmm. So they always come back to Ohio to look for some athletes. And I didn't know what they saw, except a tall, gangly kid who had, a motor. That's what everybody says. He's got a motor. He's got a motor.
Yeah.
So I'm like, all right, Miles, this is great. So Miles had the option. And a month later, he's like, Dad, what do I do? And I said, well, Miles, what do you want to do? And he basically said, I want to see how good I can be. I said, Miles, you're 6'2", 190. You're going to play against men. This is Big 12 football, power football. You may never see the field. But he goes, I go, he got into the Ivy Leagues and he wants to do finance and go to Wall Street. And he goes, Dad, he goes, why should I absorb such a tremendous debt when I want to see how good I can be in football? And I promise I'll keep my grades up. So then I'm like, well, you're not going to go to a school we never seen. So we drove out there. So we get out to Iowa State. We couldn't see the coaches. There was a realtor that showed us around just to get a lay of the land of Ames. And we were really struck by it. And it was a beautiful school, good vibe, middle of America. So that was his decision process. My daughter was going to go to Boston College, and then she applied, and she was going to run. She'd have to run really hard to make the team, but the coach was like, okay, we can maybe give her a spot. But unfortunately for her senior year, junior year, she had a tumor in her foot.
Oh.
Right underneath the sesamoid apparatus, which I took out, and thank God it was benign, and she had to do a planing of the sesamoid. And it took a while for her to recover from that. She had a schwannoma. Mm-hmm. And it took a while to alter her mechanics. And from the alteration of her mechanics, she then got a pars defect in the back. So it just never worked out for her, but she got a full academic ride to Iowa State. Mm. So we're like, wow, we got our twins going to the same school. This is awesome. Yeah. And we have fallen in love, just with the environment. It's a great school. The only bad part about Iowa State is getting there from Cleveland. There's no direct flight. Yeah. So my wife and I bought a home out there and said, we're going to make this our second home. We're going to go to all the games. And so I met Jamie Pollard, who's the athletic director. And there's a gentleman in Chardon who played football there in the late 50s and 60s who's done very well. And he's on the governing board of Iowa State. And so when they recruited Miles, they called him. And they wanted to ask about our family and this and that. He happened to be a patient of mine. So when we dropped Miles off his junior year, or his freshman year, I wrote this gentleman. He says, hey, I'll give Jamie a call. Because I said, I would love to be part of the training room, et cetera, et cetera. And I started reaching out to people in exercise physiology science program, which have, advanced degrees, and then the biomedical science, blah, blah, blah. And I'm telling you, this would never happen at any other school where I got appointed to the biomedical science department and the exercise science department as a visiting or associate professor.
Yeah.
So it gives me a purpose when I'm out there because I can teach classes. I'm doing research out there with the grad students. I'm working with mechanical engineer, biomechanical engineer, and anatomist. We're working on, my cuboid study for flat foot. I got some other ideas. And it just, I always thought I wanted to live on college campus. And this kind of kills two birds with a stone. And my daughter's out there, and it's just been a really, I won't say easy for either one of them, but I think they're realizing that it's a really good school. They're getting a great education. And, the best part is they're going to start life without any debt and be able to do what they want and have that freedom. So Iowa State for us has been great. I know you went to Iowa and you're probably cringing hearing this. I'm excited to go to the Iowa game, Iowa State game. And I think everybody in Iowa is just super, and just incredible. They just, people in Ohio are great. East Coast, they're good, but it's hard to live in the East Coast. But Iowa, it's been great. We've met so many people, so many friends. So it'll be sad when it's over. I think we'll still keep a home there. And I would still love to teach there. I mean, maybe in retirement, maybe I'll go be a full-time professor or something like that.
I've always found the rivalry interesting. So my dad played college tennis at Iowa State. So he was an athlete a long time ago. So I grew up an Iowa State fan. And then because of the medical pathway, went to Iowa instead. But it's a really interesting rivalry, I think, because I compare it to Nebraska. There is no Nebraska State. Minnesota, there is a Minnesota State, but not a big Power 5 school. Same with Wisconsin, and same with Missouri. So it's this weird thing where we're a smaller population state, but we have two big schools, and our population is divided. So it's an interesting rivalry, I think. It's not like most other Power 5 conferences out there, or I should say Power 4 now conferences. The rivalry is interesting, and it can be rather heated. So I'm one of the few that kind of straddles the line and cheers for both, because my dad did go to Iowa State, so I can pull for both.
And even though the schools have, they compete, I mean, I live in Ohio, and the rivalry between Ohio State and Michigan is just, it's brutal, right? At least there's some decorum with Iowa State. Like when we were there 2 years ago, people are nice, you get your badgering, but it's not violent, which is good.
No, people tend to kind of get along and pull together. At least, we're all Iowans. At least that's how most of us view it. So
absolutely.
Let's spin this into a little bit more medical talk. All right, let's jump into some cases here. You sent me some x-rays of an interesting case here. So why don't you talk through what the cuboid zoom osteotomy is, and kind of, I misspelled osteotomy. So anyone listening wouldn't have known, but anyone watching,
it's ostomy.
Yeah, maybe that's
it's appropriate.
Yeah, exactly. So talk through this case and talk us through what your thought process is behind the cuboid osteotomy.
Having a large pediatric population, you start seeing flat foot. And so, I've been through the run of arthroresis, which I don't do anymore. I mean, they're helpful, but they have issues, down the road. And then for me, what the hard part was understanding an Evans osteotomy. And so it just made no sense to me of let's say if you have a really complex triplanar deformity of the flat foot, breaking the calcaneus and doing a slide, and then breaking the foot, a second time to, in essence, make a 3-part fracture. And I'm not an engineer or anything like that. It never made sense. And even though the calcaneus has great bone healing, it never made sense. But even more so to me, and the Evans has been a powerful procedure since 75, at least documented, that where do you make the cut? Some literature says 1.5 centimeters, some say 2 centimeters from the calcaneocuboid joint. We all know the calcaneus is a very weird shaped bone. So if you make your cut, do you disrupt that anterior process of the anterior joint of the subtalar joint? So you can get fractures in that, you can get arthritis. And then if you really start looking dissection and you look at the anatomy, when you make that cut in that calcaneus, well, you got the peroneal tendons, but the sural nerve sticks there. And then as I started investigating it a little bit more, it's like, wow, there's not a lot of tissue covering that bone. So if you get a dehiscence, it's either tendon or nerve or bone or plate or whatever you have. So back in 96 or 97, I said, I want to try this. So I did a case and I split the cuboid and I did a calcaneal slide. And I'm thinking, well, if I could lengthen the lateral column, and still correct that Kite's angle and coverage of the tailornavicular joint, that's a cube bone. I can measure one distance to the other, find a midpoint, and cut it. And so I can't tell you the last time I've done an Evans. So I've probably done several hundred of these. Mm-hmm. Well, with the fellowship about 10 years ago, I'm trying to be, more academic and looking into this. So most people are like, oh yeah, Mark, that looks great. But, there's no literature on it. So we wrote an initial article about 2 years ago. So when I went to Iowa State, I found a biomechanical engineer who does like medical stuff, Dr. Sarah Bentel, brilliant doctor. And I sat down, I said, Doc, I'm doing this study and I would really like to see if I can physically or biomechanically or mechanically prove that this procedure is as effective as an Evans, and I can prove that there's less complications and it's an easier procedure to do. And within 5 minutes, Jeff, she goes, Mark, that's easy. I go, really? She goes, yeah, just do a finite element model study. I go, oh yeah.
Oh, why didn't I think of that?
Right? Why didn't I think of that? Thank God for engineers.
Yeah.
Literally that Sunday when I left to go back to Cleveland, there was an article out of China that did a finite element model study of the Evans procedure. So we looked at it, right? And we saw the pros and cons. And what it proved is that if you do a lateral column, an 8 mm triangular has been proven to be the best shaped graft to use. Even though you may get more correction with a rectangular graft, it puts more stress on that calcaneal-cuboid joint, Chilpart's joint. So from that, I finally got some funding last October, and I took 10 limbs. And what we did is that we did a inserton, and we put stress on. So we put a wire in the neck of the navicular and measure the distance. We put stress at 50 newtons, 100, 150 newtons to see the arch stability. Then I had undergrad, grad students, a podiatrist was there, and it was just cool just to really work with the team, show them how to do the procedure, put in the 8 mm block, and then we did that stress, and it does show that you have better arch stiffness after this procedure. And then because Iowa State, I did not need an IRB because there's no humans. We went to the vet school, and I ran down the hallway, and we were able to do CT scans. So right now, with the engineers, we're taking that information and we're looking at the stress strain with this implant and the forces that it's applied to the Chilpart's joint. And I'm happy to see that some of the results are what I anticipated. So now this next semester, it's going to be trying to collaborate and put everything there and then try to get it to submission. So I can say, here's now your physical, your mechanical evidence about this.
Yeah.
And with all my, past residents, or really my fellows who are doing this procedure, what I did learn is that in order to get a 3D spec on the foot, you have to get a CT scan. So anybody that comes in now, the third part of the study will be get CT scan before surgery, and then 6 months or a year out, so we can take a look at it, and then we can go finalize that. So for me, it's an easier procedure to do. I think if you look at the pictures, what's over the cuboid is the extensor digitorum brevis muscle belly. Mm-hmm. So you can make a small incision, split that muscle, and you're right down to that cuboid.
So I'll let you kind of.
Yeah. So there's your incision. You find the sinus tarsi. You make maybe a 5 to 6 or 5 to 7 centimeter incision, and you're right over. Now the key is you're above the peroneal tendons and you're above the sural nerve. Now, you got to be a little careful with the branch of the superficial peroneal nerve if it dives off. But if you stay right on top of that EDB, which you should see, it's right there. So then you split the muscle, and now you can see the calcaneal-cuboid joint, put a pin in it, and you can see the cuboid 4th, 5th metatarsal joint, and you can measure, and you can find your midline. So to me, finding the midline on a square or cuboid bone is a lot easier. Now, The first question people ask is, you're going to damage the peroneal tendons. Well, when you make the cut, you want to keep that blade parallel to the long axis, so you're not cutting down into that groove, and you don't break the far cortex. And then as you open that, you place your graft, and then you can place a simple 20 millimeter staple to get that controlled. And the beauty is we're not around the sural nerve, and that muscle belly covers the tissue and covers the bone.
So you go right through the EDB. You go right through the center of the muscle belly, right down, split it, get access to it.
Now, back in the days, we'd have to fabricate our own graft, and now with wedges and things of that nature, and now that's placed in. And then if you look at pre and post-op X-ray, it does swing and give you that good coverage of the talus, and you correct Height's angle.
Yeah.
And so now you make one cut in the calcaneus knee B. We even made that incision smaller if you want to do a giggly saw, whatever the case will be. And you can start these people with early range of motion. And the other key, if you do the calcaneal osteotomy, a lot of us, Aquinas is so important. So I always tell people, do you do the flat foot correction bony work first, or do you do the soft tissue release? I tend to do the flat foot or the bony work first. So that way, if I do the osteotomy on the calcaneus, I can slide it up 1.5, 2 centimeters, lock it in, and now that gives us some slack. So if we don't have to do a gastroc recession or a TAL, you can start early range of motion and get these patients up and going.
Sure.
I think obviously preoperative arthritis, is a concern. You can look at lateral column. I know a lot of people like double arthrodesis. But if you have a really bad transverse plane, sometimes a calcaneal distraction orthodesis. So similar in that standpoint. What are the downsides? Well, just like an Evans osteotomy, yes, you can get calcaneal cuboid joint stress and strain and get arthritis. I had a kid I put in 24 years ago. He's now 6'4", 350. He's got CC arthritis. I had to fuse him.
Yeah.
So, I won't say it's the end all be all, but in my hands, and that's basically what surgeons feel comfortable with, I really think that this procedure is just as powerful as the Evans, but I think there's less inherent risk with the dissection of the work of that cuboid.
So a couple thoughts on this. I think it's really interesting. It's a really kind of unique way to approach this. So hats off for kind of thinking outside the box a little bit. I think on an Evans, you're driving all of the forces towards the CC joint. And in this, maybe the biomechanical studies will refute this, but in my mind, you're kind of displacing 50% distally, 50% proximally. So it's almost less, less impaction at the calcaneal cuboid joint because it's only 50 instead of 100% of the forces.
And with
I don't know if that works out to be true or not.
And with that, Jeff, the finite element model, so we're simulating block, right? So if you put it at 80%, and you can see it in colors, right? Just like when we do our force plates, if you do 80%, you can see how the forces are much greater and in that red category if it's at 80%. Well, if you think about an Evans, you're going about 85, 90% of that bone, so you're correct. That's stress in that CC joint. But if you put that graph midpoint, the pressures, like you said, are going to be distributed hopefully a little bit more evenly. To make the graft last longer and maybe take stress off the CC joint. Yeah, you may put some stress on the cuneiform, the cuboid, fifth, fourth met cuneiform, but it's something to be considered.
Do you always fixate these? Because sometimes I'll do an Evans and I don't end up fixating. Do you usually fixate these, or always fixate, or sometimes not?
I try different fixations. For me, I'm comfortable with the staple. Just so that way, if I can start them early weight bearing in about 3 to 4 weeks, just so it maybe not displace or so.
Yeah.
So I don't think it always has to be fixated, but I think if you're going to start, especially if children start getting them up, or if there's accidents, I think it's hard to displace, but I think just for that point of comfort, I'm going to lock it in.
True. So I would say, based on the video, and I hope people go and watch the video so they can see what we're talking about. On your x-ray, on the AP, it looks like the staple is oriented laterally, but on the video and on the lateral x-ray, you can see that the tines are kind of driven inferiorly. That seems to be on purpose to avoid some of that perineal tendon irritation. The staple's pretty low profile as is, but that seems to probably be on purpose.
Yeah, you try to angle it. You want to try to get, because, that cuboid bone, it really has a depth to it. People don't realize how dorsal plantar, that's a wide bone. And sometimes, like, if you're getting in there, the fellows say, it's not open. I'm like, you got to make that cut a little plantarly and dorsally and then crack it.
Yeah. So
it really is a robust bone. And then you have to look at it and try to eyeball where you think midpoint is, right? So you have your graphs. And generally, if you put the distracting unit on, generally the staple holes fall into that area.
Sure. Have you seen any? I mean, the only downside I could think of potentially would be peroneus longus irritation as it goes under the cuboid. Have you seen any irritation with that?
I would probably have to say, honestly, probably yes. Nothing that I've never had a rupture or a cut. And if I've had one or two that I can recall, I think that maybe an injection of breaking up some of the adhesions of scar tissue underneath that groove. But to be honest with you, I have not seen, a significant amount of cases, and I can't remember, at least within a couple of years, if someone had an issue with that tendon going underneath the bone. But that's the number one question, and I think that's a very rightful question. That I think that's why angling that cut across the bone, keeping the teeth to the long axis, is important.
Sure. So we look forward to your research. Research is one of those things where we glance through a journal and we flip through and we try to find some interesting articles and I leaf through for about 5 minutes, and they don't realize the amount of time and effort and energy and dollars and all the things that go into research to prove that we should be doing what we are doing. So we always appreciate more research. So we look forward to that coming out at some point.
Yeah, I'm looking forward to it. And I can tell you, it's been a tremendous learning curve. Being in practice 29 years, you think you need something, but man, thank God for engineers, and thank God for universities where you can collaborate. I think anything that we do, collaboration is, many hands make light work. And I agree, even with research and what we do as a profession.
Yeah, absolutely. Well, I want to thank you for joining me on this episode of Pod Patrol.
Thank you. I appreciate it.
So if people want to find out more about your fellowship, so you take 2 fellows per year, and if people wanted to know more about your fellowship, I'm sure they could find the information on the ACFAS website.
Yes.
But how would they kind of find out more information about the fellowship if they were interested?
My number's out there. I'm very transparent. We are approved by ACFAS and CPME. If not the only one, then one of the few that has both certifications and approvals. We're going through the re-upping or re-credentialing this year. For me, it's been a trade-off. It's been great because the fellows challenge you. I can't do what I do without the fellows. That's absolutely 100% true. And they just stimulate my interest in learning, and a lot of times when we come out of residency, we're just in the hospitals and ORs. And what we have to realize is that it's not just surgery. It's what do you do when the complications come in? How do you make, quote, a pitch and tell somebody who had 3 opinions that maybe your opinion to do surgery is X, Y, Z? How to deal with frustrated customers and patients? How to enjoy when they have success? So our fellowship, you're going to have plenty of surgery, and there's enough work for both fellows, and they work collectively, there's academics. We work with students. We work with medical students. So it's a good combination. And then what I'm trying to do to entice and to make this program better is I've added Dr. Ayas, who was my fellow for 2 years, and she's starting to work with the fellows so they get a little bit more exposure and numbers surgically. But it's you're on the field, you're in the office, you're doing procedures, you learn how to do ultrasound, you're learning sports med, you're learning biomechanics, you're covering football games, you'll cover track meets, we'll go to the running store and learn that stuff with shoes. And what I'm trying to do this year, we did 2 years ago, I made some inroads with some of the trauma surgeons and foot and ankle surgeons in South Africa. And this year, I believe we'll have our first mini fellowship. 2 years ago, we went to the conference, the South African Limb Reconstruction meeting. And I was the only podiatrist out of 140 orthopods, and I was on faculty. And it was just one of the most amazing, gracious, it was an amazing experience. And the fellows were able to go down there for about a week and just see South Africa. So this year, I'm hoping we can get the fellows in and scrub in on, frames and trauma and all these things. So just trying to keep making this program better because, our training is better and we have levels to keep climbing. Mm-hmm. And research is definitely, required, and it's usually a 1 or it can potentially be a 2-year program.
Sure. Well, that sounds interesting. I think we'll have a lot of people interested in the fellowship, so they should reach out to you that way and get some more information. So thanks again for your time and joining me.
I appreciate your time.
Yeah, on Paw Patrol.
I look forward to seeing you when I'm out in Ames in a couple of weeks.
Sounds good. All right. Thanks for joining me on another episode of Paw Patrol with your host, Dr. Jeff Dikis.
Have a good night.